Hi everyone, thanks very much. Thanks to Amanda for organising this. So I'll just do a brief introduction for Claire. So Claire was in this room in 2009 doing a presentation as part of Jessica's relatively recent papers in neuroscience. And according to Jessica, you presented one on OCD. So here you are 5 years later giving us an update on your research. So Claire has a pretty stellar record. She graduated later on that year with a first from here in psychology, then went to the lab of Professor Trevor Robbins in Cambridge from 2009 to 2012. Did another year of postdocing in Cambridge before moving to Nathaniel Doe and Liz Phelps' lab in NYU on a Sir Henry Wellcome Fellowship, postdoctoral fellowship. Claire's publication record is pretty exceptional. From her PhD, she got one American Journal of Psychiatry paper and 2 biological psychiatry papers, which is slightly depressing or inspiring, how you want to look at it. I think I've seen bits of this talk before earlier on this year, and it's really great show. I'm sure you'll enjoy it. Thank you.
Thanks, Rob. Thanks, it's really nice to be back here. I recognise some of my lecturers and my supervisor for my undergrad project, Brandon, as well. So I'm going to talk kind of ambitiously maybe about everything that I've done since I left. So it'll be kind of a broad overview of the basic premise, which is that we can kind of explain OCD in terms of an excessive formation of habits. And I'll kind of go through a series of experiments kind of investigating that possibility and then go on to some of the new stuff I've been doing at NYU since. So when I started my PhD, I was interested in OCD, and I went to clinic and met a lot of patients, and the way that OCD was thought about for quite a long time was that these patients had really disordered minds or disordered thoughts. They believed a lot of things about the world that weren't true. So the idea is that they'd have these obsessive thoughts, which would be maybe an idea that their family would have some terrible traffic accident. And this, as you can imagine, engenders a lot of anxiety in the patient, and then they feel driven to perform these compulsive behaviours, which in the case of OCD were often quite absurd. So things like flicking a light switch to avoid this traffic accident from happening. And this is really how people thought that OCD worked. And the idea is that you flick the light switch and your family don't die, and this reinforces the relationship, and this kind of vicious cycle of OCD goes on. But the problem is when you meet the patients and you talk to them, you see that they're not deluded. They know that flicking a light switch is completely absurd. And that's what makes OCD such a frustrating and very interesting disorder, is that these patients know what they're doing is crazy, yet it takes over their entire lives, so much that they lose their jobs, and in a lot of cases they can't even leave their homes. Now I don't normally quote David Beckham, but this is one of his more apt quotes, and he describes his experience of having OCD, and he says he wants to stop but he can't. And this, I think, is just a really succinct way of describing OCD, which is in the context of a divergence between just our intentions, our will, and what we do, what our actions are. So this loss of control over our behaviour. So this kind of got us thinking, well, maybe there's something more important about compulsions in OCD that people haven't really been thinking about before. And one way that we were particularly interested in understanding this from a neurocognitive or neurobiological standpoint, and one model that made a lot of sense in terms of neurobiological overlaps was a model focused on the brain's habit learning system. So this is kind of where I started my PhD, with this kind of split or this dissociation that the brain supports, which is between what we call habits and goal-directed behaviours. So habits are automatic stimulus response behaviours that get instilled in a number of different ways, but the most common of which is just through simple repetition of actions that we do every day. And goal-directed behaviour, on the other hand, involves having a much more higher order mental map of the world and being able to use predictions to kind of guide behaviour towards motivations and things we want to do. So I'll just kind of unpack that a little bit more by describing the first study that looked at habits, and it was done in rodents in the early 80s. And what Adams did was he trained rats to press a lever, and when they did that he rewarded them with a sucrose pellet. And rats really liked this, so it was great, and the rat would perform this action, for a variable amount of time. And then Adams would give the rat the sucrose pellets for free, let him eat them, but he would pair those with injections of lithium chloride. And what this does is it makes the rat very sick and induces a really reliable taste aversion to those cupcakes or those sucrose pellets. So much so that if you give the rat the pellets for free, they won't eat them anymore. They know they make them sick. So what Adams wanted to find out here, and it was really important at the time, was, well, if we put the rat back in the operant chamber, is he going to press on this pedal, on this lever, as though nothing happened? Or is he going to update his behaviours in light of this change in motivation towards the reward? And what he found, much to a lot of people's surprise, was that rats are actually capable of showing this kind of goal-directed action selection. So on this graph here, the dark bar is a group who had an outcome devalued, or this kind of poison given to them, and then the non-devalued group are in white, and what they do is they just reduce their lever presses per minute in light of this change in motivation. But what's even more interesting, perhaps for our purposes, is he found that when you overtrain the rats, this sensitivity to devaluation goes away. And they'll go into the lab, they'll see the pedal or the lever, and they'll just automatically start pressing it, even though they won't eat the outcome of that action when they get it. So this manipulation is called outcome devaluation, and it's what we use in all of our studies, or in a portion of our studies, looking at habit biases in OCD patients. We don't give them these injections though, because that would never pass ethics, so we do much more symbolic devaluations. So the first study we did was quite a simple task, and we looked at basic instrumental learning in OCD patients followed by devaluation. So subjects were presented with boxes with pictures of fruit on the outside, and they had to learn through trial and error which was the correct action to perform in order to gain a valuable outcome, which was another picture of fruit and some points that were associated with that. And it's a very simple task, just over trial and error you learn whether each fruit calls for a left or right response, and it gets a discrete outcome. And OCD patients learn this just fine, just as controls do. Their accuracy increases with experience. But what was key is we do a devaluation manipulation after training. So these are the open boxes, or the outcomes from training. What we do is we just put a red X over outcomes that we tell participants are no longer worth any points. These are now bad fruits, and actually if you earn these fruits, we'll take points away from your total. So this is our devaluation, and then we just present subjects with rapid presentations of the stimuli from training, and we want to see if they're going to selectively decrease their responses towards outcomes that they don't want anymore, that are devalued. And so this first bar here is just the number of responses in the test stage towards a valuable outcome, and you'll see there's no differences between OCD patients and controls. But when we turn to the devalued outcome, we see that OCD patients are much less well able to selectively decrease responding towards these devalued outcomes. So like the rats in the operant chamber, they go in and they press the button like nothing happened when they see these familiar stimuli. And this was a really important result for us because, well, number one, it was the first demonstration that OCD patients do of this bias towards habit learning. But more interesting for me was the fact that we think this really exemplifies a basic behavioural deficit in OCD that's totally unrelated to their current symptomatology. So this is an extremely symbolic task that's completely divorced from any kind of intrusive thoughts or worries or anything in the fear domain. So this is the first evidence that there is something purely behavioural going wrong in OCD. But one thing this study couldn't tell us was anything about the mechanisms that kind of produce these habits in those patients. So there's kind of two possibilities that we consider at the very least, and one is that, well, maybe in OCD they're building up these associations between stimuli and responses excessively over time, and then these representations take over behaviour, they dominate, and when you see the stimulus they had more strongly formed this habit in essence. But the alternative explanation is that instead they have impairments in goal-directed control and their ability to exert motivational control over their action choices. So the idea is that so maybe they have a normal amount of habit learning over time, but they have a problem in linking their actual actions to the outcomes that follow. So this was kind of the goal of our second study, was to try and get at these issues. And so to do so, we used a new task that measured trial-by-trial decision-making in a context where there weren't any repeating trials. So there wasn't any scope for habits to build up gradually over time. So non-repeating trials, but also we chose this task because we know it's sensitive to lesions of the orbitofrontal cortex. And this part of the brain in particular is critical for goal-driven behavior, but it's also one of the most consistently implicated regions in OCD. So we had a good a priori hypothesis that it's really these goal-directed deficits might be driving habit biases in these patients. So this is what the task looked like. Subjects were presented with wheels. This is just one representative wheel. They were all different, and they'd have to make a choice at the start of a trial. So they'd indicate which one they want to play with, a ball would appear, it would spin around, we'd obscure the result from the wheel that they didn't select and tell them what they won. And we would get them at this point to rate how they feel about what they got. And then we would show them kind of nastily what they could have got had they chosen differently. And we get them to rate again. And the reason we did this is we're interested in the extent to which OCD patients subjectively experience regret. And this is kind of important in the context of our decision-making analysis that I'll show in a minute. So regret has been operationalized by a lot of people as the difference between what we got and what we could have got had we acted differently. So in terms of our trial-by-trial analysis of subjective ratings, we parameterize regret as this difference, and we use this as a predictor in a model of their satisfaction ratings. So what we find is that, like previous studies have shown, people's ratings of their satisfaction are driven not only by the value of what they won, we've taken out that variance in this graph, but they're also driven independently by this regret factor. How happy they are, they feel much better if the alternative was worse than what they got, and they feel much worse if, in this situation here, they could have won a lot more money. But what was interesting here, and what we didn't expect, was actually OCD patients experience the joy of relief and the pang of regret more intensely than do the control subjects. So OCD are in green here. So the reason we kind of we did this satisfaction analysis is because, if anything, we thought the OCD patients could have flatlined, because there's all these comorbidities with depression, for example, which might hint that they have a decrease, let's say, in just how much pleasure they take in kind of wins and losses and whatnot. But if anything, they have an increased sensitivity to regret. So this is important because what we're interested in doing in this analysis is really looking at decision making. And the reason we want to do that is because we want to look at the ability of OCD patients to make decisions based on essentially a model of future scenarios in the world, which is a goal-directed pursuit. So essentially, in order to analyze that in this task, we're measuring the extent to which individuals make choices consistent with the avoidance of regret. So we know everyone experiences regret. If anything, OCD patients experience it more. Now we're seeing if they can make choices that will minimize regret, as previous studies have shown healthy people do, even though, by the way, it doesn't make any sense to do so. It doesn't actually increase anything about what you're going to win. It's just something that humans try and avoid. Again, we operationalize avoiding regret in the context of this kind of simulation of future scenarios. So in order to kind of establish how much regret is associated with a choice, you basically take, so let's say we're going to choose this wheel on the left here. You take the worst possible case, which is you get this loss of 70, and you compare it to the best possible case from the wheel that you wouldn't choose in this scenario. And this gives you a value of the potential regret associated with this choice. We can do the same for the other wheel, and you'll notice here that the difference between the two is smaller. So actually, if you're a person who's trying to avoid regret, you should choose this wheel on the right, even though the wheel's actually the same expected value in this particular example. And we give them lots of different permutations of probabilities and possible outcomes. Okay, so just first I'll just show you one of our control measures, which is the extent to which everyone's choices are governed or are influenced by the expected value of the wheels, which we expect to be quite pronounced, and indeed it was. So this is, the difference between expected value of the two wheels, and this is the probability that you'll choose one wheel versus the other. And you'll see it's a very strong predictor of choice behavior, and I hope maybe you can see that there's no difference between OCD patients and controls. The lines are completely overlapping there. But when we turn to the extent to which potential regret influences choice, like previous studies have shown, so this is the control participants here, this kind of irrational choice to avoid regret is a significant predictor of choice behavior in the controls. But this effect is attenuated in OCD patients. So despite the fact that they actually feel regret more intensely, they're less well able to make choices consistent with its avoidance. So we interpret this as a failure to use action-outcome simulation to guide choice behavior, to use these future scenarios to make choices consistent with the avoidance of something that they don't like very much. So we've kind of probed this, we've used this decision-making angle a couple of times since, and the results are kind of all converging on this point that it's this ability to make predictions about future outcomes of your actions that appears to be deficient in OCD. But at this point we kind of, we're honing in on a mechanism, but there's kind of a big gap, and that's that habits in OCD are avoidant and they're not appetitive, and this is something that's very important for understanding and treating the disorder. OCD patients don't feel compelled, for example, to consume food rewards or drug rewards excessively. Rather, they feel compelled to perform actions because if they don't, they feel this overwhelming sense of anxiety. This fear is associated with the action. So in order for us to put it another way, if habits are a viable model of compulsivity in OCD, then they must relate to fear in some way that's important for the disorder. So this is something we wanted to tackle in a new study. So we designed a new task which would look at avoidance learning in OCD patients. And it was a really simple paradigm in contrast to the last study. So there were just 3 discriminative stimuli, and they predicted shocks to participants' wrists, so mildly aversive electric shocks. So we would expose them to these associations and then tell them that, okay, now you can avoid all of those shocks. And it was a very easy paradigm, not many people were harmed in the process. So all you had to do was, if you see the blue square, you respond on the right side of a foot box, and you can cancel the shock to your right wrist. And you can do it on, the response is 100% effective at cancelling the shock. So all subjects learn this again pretty easily, and they don't get very many shocks at all. So after a training stage, critically we do a devaluation procedure. So this is what the subject looks like. They're hooked up to 2 shocking machines, and we disconnect one of their wrists in front of their eyes. So there's kind of like a middle connector that we unplug, making one side no longer threatening and the other side still threatening or valued. So we do this, as I said, in full sight of the patients, but then we also compound that by saying, okay, you can no longer be shocked to this wrist, and your only task is to avoid the remaining shock. So we're extremely transparent about what's expected of participants, and we did this because, OCD is associated with all this kind of irrational thinking, and we didn't want there kind of to be room for anyone to misunderstand the instructions and whatnot. So it's extremely transparent. Yet, despite this, we still found our effect, where OCD patients continue to respond at a higher rate than controls to avoid a shock that can no longer be delivered. And again, these results I think are quite striking, because this is a 30-minute lab experiment. We're actually inducing these automatic habits where they'll perform these actions that are really quite absurd in the context of the experiment. So as I said, the point of doing this study was not just to replicate these habit biases, but rather to try and understand how they relate to fear and irrational thinking in OCD. So to get at this, we measured physiological arousal during this study in the skin conductance response. And we didn't find any evidence that, for example, increases in skin conductance response or the fear response were causing habit biases in OCD. So what you see here is just the general habituation of the skin conductance response that happens with overtraining of kind of repetitive action. So this is relative to the participants' baseline during training. In this stage, everyone's quite calm and relaxed in the evaluation test. So it's a no result, but at least we don't have any evidence that suggests that these OCD patients were more fearful or believed us any less that they could no longer be shocked in this study. So no evidence that fear is driving these responses. We also decided to take some more subjective measures of people's understanding of the task, etc. So one was we asked subjects to report their levels of shock expectancy, and we did this after the study, but we've since replicated it at different time points in the study. And we just said, how likely was it that you'll get a shock how likely was it that you would get a shock following the stimulus in the devaluation test? And what we find is that everyone's ratings are right down at the floor, so that whereas they were up at 95% beforehand. So everyone reduces their shock expectancy after I unplug the electrodes, essentially. There's no differences between the 2 groups. To kind of further, again, compare this result, we carried out a devaluation sensitivity test. And what that is we essentially carry out the devaluation manipulation earlier on in training as well. So before we've actually induced the habits through overtraining, we do this little unplugging procedure kind of right at the beginning before the habits have had a chance to get inset. And when we do this, we see no evidence for habit biases in OCD. So early on in training, before we induce the habits, if I unplug the electrodes, the OCD patients are perfectly well able to understand this means I'm not going to get shocked anymore, I can reduce my responding. So again, we think that these kind of cognitive interpretations there's no evidence that these kind of cognitive interpretations can explain this behavioural deficit or this bias towards forming habits in the context of the task. And then a little more qualitatively, in this study, one thing I was interested in doing was trying to bridge somewhat of a phenomenological gap between what we think of as a habit and what we think of as a compulsion. So habits are, in everyday life, we think of them as like automatic little slips or accidents we might perform when we're not paying attention, for example. But in OCD, compulsions are not like that at all. Patients are all consumed with thinking about them, performing them, and they feel a very real premonitory urge to perform them, which not a lot of us would think about saying in relation to habits at the very least. So what we wanted to do was to ask subjects in this study if they felt an urge to respond. So rather than being an automatic response they're not aware of, do they recall feeling an urge to perform these actions, these redundant actions? And we found this was the case, that both groups experienced this kind of urge to some extent, and this was greater in the OCD patients. And then finally, and perhaps most interestingly, in my opinion, we took, at the end of the study, we asked, I guess the really obvious question, which is, well, why did you respond? You know, you've rated all these things like, oh, I didn't think I'd be shocked, you know, we know you're capable of understanding this procedure, why did you perform these habits? And what we found was that a lot of patients would report things like, oh, it was automatic, it was a habit, I wasn't really thinking. But a decent portion, 9 out of 25 of the patients, reported that things like this. So they said, oh, well, I guess I thought it might shock me somehow, or I guess I thought the shock would go to the other wrist this time. And a lot of kind of weird and very unusual explanations for behaviour. And this was particularly striking because, you know, we went back and checked, and these are the same patients who reported, you know, when we asked them earlier on, they reported no shock expectancy. They knew they couldn't be shocked. It's only after we draw attention to the fact that they performed this habit that their brain starts to fill in the gaps and come up with an explanation that makes sense for these otherwise really senseless behaviours, these habits. So it's very preliminary, it's very exploratory, this kind of explanation. And it's something we're following up at the moment. But we think that in the context of this study and in OCD more broadly, there's scope that maybe OCD patients build up these habits or have a tendency to form these habits, and then the rational thing for our brains to do is come up with fears, which are explanations for avoidance behaviours that otherwise don't make any sense. So it's a possibility that through a mechanism of perhaps cognitive dissonance, that patients say, okay, well, if I feel the need to wash my hands, then I must be afraid of germs. And this is something, again, that we're testing causally now in healthy subjects at NYU. That's something I'm quite interested in, we can talk about later. But back to these experiments. So I'm going to show you one more on this theme, which is coming out on Friday. And it's a study looking at the neural basis of this imbalance in the context of this avoidance task. And let me just take a sip of water. And the reason we did this is because we have this, what we think is a really nice model of OCD, and it certainly has face validity, but we're doing all these tasks kind of on an island, and we want to make sure that what we think we're tapping into converges with, for example, basic work in rodents, of which there's been a wonderful, there's a very rich literature that shows dissociable brain circuits that do support the balance between actions and habits. And we want to make sure that the habits we're seeing in OCD patients converge on these brain structures. But also, again, what we're trying to do is add some more specificity to our model in terms of the mechanisms. We have indirect evidence that there are goal-directed deficits in OCD. This makes sense based on inference that these are causing devaluation biases in this other strand of research. So we want to see that in the context of a devaluation test, if we see failures in goal-directed learning that are actually driving these biases. And as I said, there's this really wonderful cross-species literature that has dissociated the neural substrates of goal-directed actions and habits. And in particular, the caudate nucleus, and the medial lobar frontal cortex have been most consistently implicated in goal-directed control. And the evidence for this, I mean, this is by no means exhaustive, but comes from the first studies in lesions in rodents, more recently optogenetics in mice, human DTI tractography, functional imaging and structural imaging in humans. It's one of the best, I think, well, maybe I'm just exaggerating, but there's a very impressive convergence across species and across paradigms in this particular domain. And we're drawing on that in this study to make our inferences. Secondly, and likewise, there's a similarly impressive wealth of studies that converge on the importance of the putamen in the formation of stimulus-response habits over time. So we have a priori hypothesis based on the behavior that goal-directed deficits are driving habit biases, but we also have some evidence from imaging work in humans with OCD, of which the most consistently implicated regions are the medial orbital frontal cortex and the caudate nucleus, which are in OCD, and they're hyperactive at rest, and this gets even worse when you provoke their symptoms. And if they have a good response to SSRIs or CBT, this hyperactivity goes down again. So these regions are really critical for OCD. And so what we're doing in this analysis is we're seeing if habit biases are associated with hyperactivity in the caudate, medial orbital frontal cortex, or instead we're going to see some changes in the putamen with training that can explain these deficits. So I'll explain the analysis, which is a little complicated, not too complicated, but as any of you do, or many of you who do imaging will know, there's kind of a major confound inherent in trying to compare brain activation between groups of people who are performing differently or responding differently. So you don't know if what you're getting is just the effect of someone pressing a pedal versus not pressing a pedal, put very simply. So to get around that, we think is quite a clever protocol where we have these two stimuli that are trained, or two actions that are trained for an equivalent duration of time. So what we do is we have a bunch of OCD patients, and at the end of training we do this devaluation test. This is the shock study again, but this time in the scanner. We disconnect their electrodes, and we put them through the habit test, and we use their behavior to index which patients have a habit and which don't. And then we compare their activation to the valued stimulus. And what the valued stimulus represents is the online, unperturbed performance of a habit. So everyone's responding at an equivalent rate to this stimulus, but some people have habits at this point and others don't, and we can index that from the devalued stimulus. So I hope that makes sense. I'll just kind of spell it out again. So for the task comparison at the first level, we're comparing activity, brain activity, to the valued stimulus minus the safe stimulus, which just comes on the screen, but they don't respond to. And at the second level, we're comparing within the OCD population those patients who have formed a habit at this time point to those who have not, indexed by their responding to the devalued stimulus. And stop me if that doesn't make sense to anybody. And importantly, again, we don't have any differences in terms of behavior to the valued or safe CSs, so those confounds don't apply to us. So the results, what we found when we do this analysis is we find this really strong hyperactivity in the caudate nucleus in OCD patients who have habits relative to those who don't, and the control subjects are somewhere in between the two. It's primarily on the left, but extends over to the right caudate at a more liberal threshold. And moreover, instead of kind of doing this breakdown of who has habits and who doesn't, if we take the continuous variable of subjects' self-reported urge to respond, this same region pops out of our analysis, and we have this linear association between how much people reported feeling this habit urge and the strength of their activity in the caudate during this task. So this, as I said moments ago, the caudate, along with the medial orbital frontal cortex, are regions we know are critical for goal-directed control over action. So we think this is evidence to suggest, or to kind of go along with a number of other kind of little data points that I've been presenting so far to suggest that it is dysfunctioning goal-directed structures that are causing these habit biases in OCD. But we wanted to test the alternative hypothesis as well, and that was, well, maybe we can predict habits in the test from how people learn early on. And one possibility is, maybe these habits are building up excessively in the putamen, and this is also maybe contributing to habit biases in OCD. And this is just to remind you, or show you the accuracy of the avoidance learning over the 4 blocks of training in the experiment. And you'll notice this is like 50% at the bottom, so everyone's extremely good at this task. It's very, very simple, very repetitive. Okay, so to try and analyze changes in activity over time, we do a comparison where we compare the warning stimuli, so this is the left and the right together, nothing's been devalued yet, minus the safe stimulus, and we use a parametric modulator of blocks. So we're looking at activity that will increase or decrease with extended training, and we want to see if that will predict who forms a habit later at test. So to do that, we compare the OCD patients who have habits to those who don't, but we also want to see if there's any broad scale differences between OCD patients and controls who are in this analysis or during training matched in terms of their behavioural performance and accuracy. Now, unfortunately, we didn't find any brain activity that could predict who would form a habit later at test, but we did find this really striking effect in the medial orbital frontal cortex, such that OCD patients showed this pattern of hyperactivity, particularly during the first blocks or the initial encoding of the action outcome representations. Now, again, we know that the OFC is really important for goal-directed control over action, but what's eluding us here, and perhaps just our design is just not nuanced enough to kind of get at these mechanisms, we can't kind of find the link that translates this initial hyperactivity, like quite striking hyperactivity in OCD, to their later performance of habits at test. But this is something we're going to try and push on a little more in the future. So I'll just, it's more like a 3/4 summary. So these are all kind of the studies I did during my PhD, and so I hope I've convinced you that OCD is associated with excessive habit formation. We've done now 5 separate studies with 5 cohorts, and I think maybe 4 completely different paradigms, all kind of honing in on the same issue, and we get the same effects. We've done this kind of avoidance study twice. We've seen no evidence that these habits in OCD are driven by fear or irrational thinking. And we've observed that habits in both the studies, again, are associated with this feeling or this urge to respond. And then the final piece is that we make inferences from our fMRI study that goal-directed brain regions are important for, or disruption in these goal-directed regions are important for habit biases in OCD. So, finished my PhD, and then I was like patting myself on the back, great, goal-directed learning causes OCD. Now we just find a drug that fixes that, and then we can fix OCD. But of course the reality is that that's not true, and even if we do find this drug, or this behavioural therapy that works on goal-directed control, which we could do, it probably wouldn't be more effective in OCD than SSRIs are. And the reason for that is that in psychiatry research and in psychiatry practice, we're making an assumption about the world, and that's that it looks like this, and we can group people based on these kind of superficial signs and symptoms and give them labels like OCD, depression, anxiety, and then of course the magical group of controls who have nothing wrong with them, and then we can, give them treatments that are targeted for these particular disorders. But the reality is that this just isn't the case, and in fact the world looks a lot more like this, and what we're doing is we're grouping people based on maybe a preponderance of symptoms or a certain combination of symptoms that we think are particularly relevant. And the consequence is that for research we're getting extremely noisy results, and we're getting extremely poor specificity across these different disorders, but even more worryingly we're getting this really noisy response to treatment in practice as well. So in light of this, the new focus of my work at NYU is to try and establish biologically relevant traits that predict indices of psychiatric or psychological discomfort or problems or disturbance in patients. And to do that, we've been working on this new thing called transdiagnostic traits. Which I just need some more water. So the idea is, and a lot of researchers are pushing for this now, is we can look at, instead of superficial signs and symptoms, we can look at something that has more biological relevance, and then in turn we can get more specificity in the treatments that we develop. And the dream scenario is we can, of course, meet an individual patient and target a therapy to them, rather than like a broad class of individuals who we think are homogenous, but who of course are not. And so the idea, it's a work in progress, but we have some ideas for conditions that need to be met in order for something to be considered a transdiagnostic trait. And the first is we think there's no reason that it shouldn't be dimensional. So there's no reason to think that there's these categorical shifts occur, but instead that we should be able to track or we should be able to relate normal variance in, let's say, compulsivity to normal variance in goal-directed learning abilities, for example. Secondly, and really importantly, we think that these, as the name suggests, that these should be generalizable. So other disorders that are characterized by compulsion, like addiction or binge eating disorder, should show a similar relationship between the compulsive features of their disorder and this deficit in goal-directed learning. And then finally, and perhaps most importantly, is that these should be specific. So there should be disorders that, or there should be psychiatric characteristics or features that are totally unrelated to these deficits in goal-directed learning. And the reason for this is or the worry here is if these effects aren't specific, we're just targeting some, broad-scale dysfunction that's associated with, life stress or any of these other things that go along with psychiatric disorders, and that's not going to give us any specificity in the development of new treatments. So the question that I've kind of started to try and answer is compulsivity a transdiagnostic trait? So we've done kind of 2 studies looking at this so far, and they're just very brief. So the first is we wanted to test if these effects are generalizable, and a colleague of mine at Cambridge took this on. And so she measured goal-directed learning across 3 disorders of compulsivity. And she found deficits in OCD patients, like we've been talking about today. She also found similar deficits in methamphetamine abusers, and again, a similar pattern in patients who have binge eating disorder. So these are 3 disorders all characterized by compulsion, and moreover, she found similar neural correlates to what we've been talking about earlier, such that goal-directed learning is associated with increased volume in the medial orbifrontal cortex and also the caudate, which I'm not showing here. But these 2 regions are related again to performance in healthy people and in these patients at these goal-directed learning tasks. So this is good. We really want to see that compulsion is not something unique to OCD, or goal-directed deficits isn't unique to OCD. It goes with compulsion in general. But the problem here, of course, is there's no positive control group. There's no group that we don't expect to see a deficit in, and this could just be something associated with a group of people who have a lot of problems in their life. Lack of employment, a lot of other issues. So what we really want to assess is, do we see this association in the general population across a broad range of individuals? And moreover, are these effects specific? Are they specifically related to compulsion but not anxiety, for example, and not depression, for example? So to get again, so as I said, does normal variation in OCD symptoms selectively predict goal-directed deficits? So this is a work in progress. I call this, I guess, a pilot study, but I've got a really big N. So it's a study that we've conducted online using Amazon's Mechanical Turk, where we get subjects. We've made these web-based applications where subjects can take part in a reinforcement learning study, an experiment at home, just like a kind of computer game essentially. We get them to do this. We get them to do some self-report questionnaires, and we also use IQ as a covariate. So the questionnaires we use in this task, or in this study, are questionnaires looking at OCD, depression, and anxiety. A colleague of mine at Stanford has developed and validated this alternative version that we can use online, which has been really great. I'm about to finish up now, but so we had this question: are they selectively predictive of goal-directed deficits? And we found they were in this broad-scale sample. So these are OCD scores, and this is your ability to be goal-directed in one of these tasks. And we see a negative association, such as the higher your OCD symptoms, the worse you are at goal-directed control. In just a normal sample of 580 subjects, well, as normal as Mechanical Turk subjects are, we take them in and we see this association in the general population. Most interestingly, in my opinion, these effects survive inclusion of depression and anxiety in the model, and there are no effects of depression and there are no effects of anxiety on this goal-directed deficits. So, just trying to sum up, so far we've established that these deficits are dimensional, I'm not sure what's going on there, that they're generalizable across addiction and binge eating disorder, and then perhaps most importantly they're specific, so we don't see these changes in anxiety and we don't see them in depression. So what we're working on now is basically just replicating and expanding on this study, so looking at other disorders that we don't think involve an aspect of compulsivity and other disorders that we do think it might play a role in. We're just really trying to push on linking this kind of neurocognitive performance to phenomenology that might be informative for treatment in the future. So I'll end there, and thanks very much for listening, and these are all my collaborators, and in bold are my supervisors from various stages, so thanks to them. Thank you.
first. I'm not very familiar with the new idea of the trans diagnostic stuff.
Yeah.
Presumably there are other labs or researchers working on different traits then as well.
Yeah, so it's actually a really significant initiative that's been started in the United States by the National Institute of Mental Health and Tom Insel, who's the director. And it's called RDoC, or Research Domain Criteria. And it's a really wonderful thing the NIMH are doing in that they've said they're not going to fund any research that looks at DSM disorders anymore at all. So what you can do is instead, if you want, you can try and study anhedonia. And you can take in a bunch of, you can take in schizophrenia patients and depression patients and try and really understand what that trait is and what kind of brain structures it's related to, what the pharmacology is, etc. And they're really trying to say, okay, we just have to throw out everything we've been doing so far, kind of get right back to the basics, understand how biology, neurocognition, genetics, how all these things relate to disturbances that people have in the psychiatric domain. And then we'll bring that towards treatment. But if we're trying to design treatments to fit these DSM categories that a bunch of people voted on in a room, we're not going to have much luck. That's the idea.
Did you ever look at any structure, like structural correlates of that? So, like just a T1 scan in the...
No, I haven't done that, but they, well, I guess I kind of have. I'm like a middle author of 15 on that Voon paper I showed. So they have these, so they looked at brain volume in the control subjects and in the binge eating patients.
Okay.
And so they find that how goal-directed you are depends on how big your OFC or your caudate is, and they find that those regions are smaller in the binge eating disorder patients. But I haven't done that myself.
So yeah, great talk, really enjoyed it. You mentioned briefly that you kind of qualitatively spoke to people. Can you tell us a little bit more about that? Very interesting.
Well, so, I mean, there wasn't much. I just had one question written down, which was, why did you keep responding in the last stage, and it didn't apply to everybody, obviously. As simple as that, and they just had to write down their answers. But it was, I did it first in the pilot study, and we had a couple of OCD patients, and like the first one or something said this, and I just found it really striking. I was like, no, you didn't. Like, I know you didn't, because you performed fine at the earlier devaluation test. And then it kind of just like, it stuck with me ever since that maybe this is actually how it works, and maybe, our brains are just really good at making up stories that make the world make a lot more sense, and that maybe that's, unfortunately, how these kind of fears come to be in OCD. So we're trying to test it, as I said, causally now, just in healthy people, and seeing if habits change how much they're willing to pay for food. It seems a bit far removed, but it's like the first step in trying to see if habits change how we value things in the world, for example. And then we'll kind of move, if that's successful, we move it to the fear domain.
Thanks for a very interesting talk there. You measured fluid intelligence in the large-scale pilot.
Yeah.
Why did you do it, and what did you find from that?
So it's a covariate, because these high-level tasks are correlated with just general fluid intelligence. So the task that we used, I didn't go into much detail. I'm not sure if it's like worth showing. Let's see. So it's a reinforcement learning task that, if any of you know Nathaniel Dawes, my current supervisor, is kind of famous for. And you've got this kind of setup of future states, and you're making choices. And maybe get rewarded, and if you get rewarded, you do it again. And then we look at goal-directed learning, which is the extent to which if you make a choice and something weird happens, like it brings you to the wrong place, will you then use that information in a kind of goal-directed manner and change your choice to go somewhere you know is more likely to bring you back? Just very briefly. So this kind of a task and these kind of higher order tasks are related to IQ, and what we want to do is just make sure that it's not just this bad brain hypothesis, that it's just like something that goes along with failure to perform, broadly speaking, in tests. So we include it as covariate. It doesn't relate to OCD symptom severity or anything like that, but we can just take out the variance associated with general IQ.
I'm kind of linking to the qualitative piece, just from like group facilitation of people with OCD. I think there's an awareness of this, because a lot of people would say it feels like a habit, or like it's kind of linked to boredom, I think, rather than neatly to like obsessions. But particularly I think with trichotillomania, have you any, what type of OCD do most of your people have?
So we haven't done studies with trichotillomania, but the prediction's exactly the same as kind of you've suggested. So it's the patients that I dealt with at Cambridge were really refractory patients, so they fail in the regular clinics and then they go to the specialist OCD service, so they're very severe, but the stuff is all like a wide range of symptoms, checking, washing, what have you. But for all of the studies I presented, they're free of any comorbidities, so they don't actually have trichotillomania as well. They wouldn't be allowed in the study if they did. And that's just the way that we kind of started to approach the problem, to try and see if things are specific to OCD. But now, of course, I think it's just important to take everybody in and look for these kind of dimensional markers that cut across the disorders. And trichotillomania is certainly one that I think would be explained by this phenomenon.
The treatment, like were the patients at the time or people with OCD undergoing any treatment that you control for that in any way?
It's a really good question. So in the first 3 studies, we don't control for it. We take note of it, but again, these are really treatment-resistant patients. So they're basically all medicated, and most of them are on SSRIs, but a lot of them are also taking D2 antagonists, which is pretty common for these refractory patients. But in the last study, the imaging study that's coming out on Friday, we have a split of unmedicated patients not taking any treatment versus those who are on a wide range of different things. And we don't see any differences associated with the treatment. That's not to say the treatment doesn't affect it. It's just, it's kind of whichever way you do it, it's a bit of a fraught methodology. So the medicated and unmedicated are matched for symptom severity. So it's hard to know unless you do a pre-post study in the same subjects what exactly the medication is doing. But we have some indication that it's not driving our effects, it's not causing them. That's what we're maybe worried about.
Thank you.
Yeah.
Thanks very much, Claire. That was a really interesting presentation. Thanks
Thank
very
you.
much. Thanks.